Hello everyone, hope all of you are doing well. Welcome to the second part of recent updates. We had uploaded first part of recent updates a week ago. For those of you who have not watched it yet, you can go to our channel and check out that video. Second part of recent updates is said to be more extensive because of the conceptual understanding involved in the topics below. Beginning with the most important one, the recent NICE guidelines of asthma. According to the, you can see in the parenthesis, we have given the link to the guidelines, which you can read yourself if you have quite amount of time. Other than that, we will be telling you the most important parts of the guidelines which have been uploaded in on the website. So according to the recent NICE guidelines, for all the people, we have to start treatment immediately if they are acutely unwell or highly symptomatic at presentation. Objective tests can be performed which may help to support a diagnosis of asthma, which include eosinophilic count, FeNO, that is fractional exhaled nitric oxide, spirometry or peak expiratory flow before and after bronchodilator, only if the equipment is available at site. However, if objective tests for asthma cannot be done immediately, for all the patients who are acutely unwell or highly symptomatic at presentation, carry them out when acute symptoms have been controlled. Also be aware that the results of spirometry and FeNO tests may be affected in people who have been treated with inhaled corticosteroids before. However, the test results are more likely to be normal even in them. So according to the recent NICE guidelines, which is in association with BTS, that is British Thoracic Society, and SIGN 2024, in adults with history suggestive of asthma, blood eosinophilic count or FeNO has to be performed first. FeNO threshold of greater than 50 parts per billion is considered to be positive. In patients where FeNO can't be done or blood eosinophilic count can't be done, we have to, or it turns out to be normal, we have to measure bronchodilator reversibility with spirometry. So, as with GINA guidelines, we have to diagnose asthma if FEV1 increases 12% or more and 200 ml or more from the pre-bronchodilator measurement. So basically, if we have to take two values, one before the one spirometer value before the application of bronchodilator and one after the application of bronchodilator, and we need to measure the increase in FEV1 after the bronchodilator application. However, in cases where this all can't be performed, we have to measure peak expiratory flow twice daily for 2 weeks and diagnose asthma if there is peak expiratory flow variability of 20% or more. In cases where asthma is not confirmed by all these above methods but still suspected on clinical grounds, consideration for bronchial challenge test needs to be done. So if bronchial hyper-responsiveness is present, then we can diagnose asthma. These are the guidelines for the adults greater than 18 or 16 years according to BTS NICE sign. However, in children with history suggestive of asthma between 5 to 16 years, we have to start with FeNO, fractional exhaled nitric oxide, and the threshold for children is 35 parts per billion. Diagnose asthma if it's more than that. If FeNO is not raised or is not available, measure bronchodilator reversibility with spirometry again. So this value is the same for adults and for children, that is the increase in FEV1 by 12% or more from baseline, or if the FEV1 increases 10% or more of the predicted normal FEV1. In cases where spirometry is not available or is delayed, measure peak expiratory flow twice daily for 2 weeks, same as adults, and diagnose asthma if PEF variability is 20% or more. If asthma is not confirmed by all these above methods but still suspected on clinical grounds, perform skin prick testing to house dust mite or measure total IgE level and blood eosinophilic count. So this is the difference between diagnosing asthma in adults and in children. aged 5 to 16 years. In children, we perform a skin prick test. However, in adults, we perform bronchial challenge test. However, in children less than 5 years, the diagnosis is hard because we can't obviously tell the children to start to follow the spirometry protocol. So, in such children, since there is no good reference standards, anyone with suspected asthma needs to be treated with inhaled corticosteroids at first, in recommendation with the medicines for children under age of 5, and then review the child on regular basis. If they still have symptoms when they reach 5 years, then you need to go back to the testing methods for the children 5 to 16 years and then attempt all the objective tests. However, even after reaching the age of 5 years, if the child is unable to perform objective tests, then try doing the test every 6 to 12 months until satisfactory results are obtained, or refer for specialist assessment if the child's asthma is not responding to treatment. So other than that, another important guideline is if any preschool child who requires admission to hospital because of respiratory or breathing difficulties, or 2 or more admissions to emergency department with wheeze in 12-month period, we need to start treating them with inhaled corticosteroids or refer to a specialist respiratory pediatrician. So these are the BTS, NICE, SIGN collaborative guidelines of 2024 for asthma. We all have been studying GINA guidelines for treatment for asthma. So remember BTS guidelines for diagnosing asthma. So second most important topic under recent updates is the gold update of COPD. Some important definitions before we go ahead to the most important update of classification of COPD. Some important updates in gold COPD are: young COPD is any patient who develops COPD between the age of 20 to 50 years. As we know that lung function peaks at around 20 years and starts to decline around 40 to 50 years. Gold has proposed young COPD category. Pre-COPD is been proposed to identify individuals of any age either with symptoms or structural deformities or functional abnormalities. Functional abnormalities may include hyperinflation, reduced lung diffusion capacity, rapid FEV1 decline in the absence of airflow obstruction on post bronchodilator spirometry. So if there is airflow obstruction on post bronchodilator spirometry, that straight away points to the diagnosis of COPD. So the important thing to note here is there should be absence of airflow obstruction on post bronchodilator spirometry. However, all these pre-COPD patients should already be considered patients because they already suffer symptoms or are functional and or structural abnormalities. Moving on to the another important topic under COPD is the genetic risk factors which have been listed under GOLD. So the important thing to note here is mutations in SERPINA1 which leads to alpha-1 antitrypsin deficiency is the most relevant genetic risk factor for COPD. Among that also, it should be homozygous ZZ, that is PIZZ phenotype. PIMZ or PISZ do not possess any additional risk of COPD. These are heterozygotes. However, please note that these patients should be non-smokers. Coming to the most important part, the combined initial COPD assessment. We all knew that there was a table for GOLD classification for COPD where we had A, B, C and D criteria before. However, we have moved on now to A, B and E most recently. This has been cut out and we have just left out with A, B and E. So why did they change it to ABE. That is because the importance of exacerbations is independent of the level of symptoms of the patient. तो यहाँ पे if there is more than 2 moderate or 1 exacerbation which leads to hospitalization, then irrespective of the patient's symptoms, we need to consider it under one category and treat it as the same. So this is the most recent GOLD Gold 2023 update. So these are in gold category. We need to remember that here we have the MMRC grading and here we have the exacerbation history. So how do we treat such patients? Initial pharmacological assessment for such patients when they first present with symptoms of COPD and are confirmed with COPD on spirometry with clinical history needs to be remembered that group A is treated with a bronchodilator. Group B, we know that there is 0 or 1 moderate exacerbation but there is no hospital admission. But however the patient is a bit more symptomatic than group A and hence we need to treat them with both the LABA and LAMA dual therapy, not just monotherapy. However, for group E, we need to start them on LABA, long-acting beta agonists, and LAMA along with ICS, that is inhalational corticosteroids, if blood eosinophilic count is greater than 300. So this is the initial pharmacological assessment, and after that, if the patient is followed up, we need to remember that if the response to initial treatment is appropriate, then we need to maintain this initial treatment, that's all. However, if there is no appropriate response to the treatment, check the adherence and inhaler technique of the patient. Then consider predominant treatable trait to target, that is dyspnea or exacerbation. Then after placing them in the predominant treatable trait, check if the patient falls under dyspnea category. That is, if the patient is still having dyspnea in spite of having been on initial assessment pharmacological therapy, then you need to switch to LABA plus LAMA if he was only on monotherapy, that is LABA or LAMA initially. And even after that, if the patient is not responding well, then you need to switch inhaler device or molecules, implement or escalate non-pharmacological treatments, and investigate or treat for other causes of dyspnea. If the patient is falling under the trait of the exacerbations, again, if the patient is on monotherapy of LABA or LAMA, check the blood eosinophilic count. If it is greater than 300, straight away start on ICS, that is inhalational corticosteroids. If it is less than 300, then initially try LABA plus LAMA dual therapy, and again again check the initially measured eosinophilic count. If it was more than 100 and if the patient has not responded to LABA plus LAMA, then go ahead with ICS. However, if the patient's blood eosinophilic count is less than 100, then the guidelines suggest that ICS might not be helpful, and hence we need to start the patient on roflumilast if FEV1 is less than 50% and azithromycin if the patient is a former smoker. So this is the most important GOLD Gold update for COPD. Moving on to the third part, I have mentioned question mark after NTEP new regimen because this has not yet come in India, but it is potentially going to be updated in 1 or 2 years because this has been already the new guidelines have already been formulated by CDC and American Thoracic Society. So let's begin with just basics of drug resistance in India. This is the link for the guidelines which have been published by the NTEP, National Tuberculosis Elimination Program by India, and the data is taken from there. So drug resistance scenario in India is more because of India contributes more than a quarter of global drug resistant TB cases, and out of which 60% were MDR or RR TB cases, 90% of which were initiated on treatment, and 11,000 were pre-XDR or XDR TB cases, of which 89% were initiated on treatment. So just giving a brief insight into what the categories of TB drug resistance are. There is a category of monoisoniazid or polydrug resistance, where the person is resistant to isoniazid, but the person is definitely sensitive to rifampicin. The patient may or may not be sensitive to fluoroquinolones and group A drugs, which are bedaquiline and linezolid. However, remember that in rifampicin resistant cases, the patient is definitely going to be resistant to rifampicin. In MDR-TB cases, the patient is definitely going to be resistant to both isoniazid and rifampicin. Rest of the drug sensitivity may be unknown. In pre-XDR, the patient is resistant to every drug except the group A drugs of bedaquiline and linezolid. And in extensive drug resistance, the patient is resistant to all the categories of drugs, that which may include at least one fluoroquinolone and one group A drug. So the National Technical Expert Group under NTP had recommended developing a protocol with guidance document for the WHO recommended guidelines, which introduced recently BPAM regimen under programmatic condition, which also suggests that bedaquiline and delamanid has to be introduced in all age groups, considering the unmet need of this population. Also, they wanted us under the NTP guidelines to adopt the modified shorter oral MDR-TB regimen with linezolid replacing ethionamide. So this was the NTP guidelines which had recently introduced BPAM regimen. However, the most important thing is the new ATS or American Thoracic Society and CDC combined guidelines, the link to which has been given in the bracket here. So what does these guidelines suggest? So any patient who is isoniazid susceptible, rifampicin susceptible, and in an adult patient, that is age 12 years or older, the patient is considered to be drug susceptible because of the susceptibility to isoniazid and rifampicin. We can recommend the use of a 4-month regimen of isoniazid, rifapentine, moxifloxacin and pyrazinamide. So this is a conditional recommendation and moderate certainty of evidence. So our earlier 6-month of regimen has now been shortened to 4 months as proposed by ATS CDC guidelines. This will be adopted soon, so these guidelines need to be remembered. In any non-severe but presumed isoniazid and rifampicin, in any non-severe but presumed isoniazid and rifampicin susceptible TB of children aged between 3 months and 16 years, we need to remember that we can the ATS CDC has recommended the use of 4-month regimen of 2 HRZ and 2 HR rather than 6-month drug susceptible TB of 2 HRZD and 4 HR. So here we know that we can just have 2 months of 2 HRZD and 2 HR, which is equal to 4 months instead of the traditional 2 plus 4. This is also having strong recommendation, and hence this will definitely be introduced in future, and it has moderate certainty of evidence. Moving on to the next one, rifampicin resistant but fluoroquinolone resistant TB. That is, it is resistant to both rifampicin and fluoroquinolone. So in any adolescents aged 14 years and old, and in adults with rifampicin resistant pulmonary TB with resistance or patient intolerance to fluoroquinolones who have not had any previous exposure to bedaquiline and linezolid or have been exposed for less than 1 month, we can recommend the use of 6 months BPAL regimen rather than the 15-month regimens. So BPAL regimens for any patient with rifampicin plus or minus fluoroquinolone resistance is recommended nowadays. And in cases with rifampicin resistant but fluoroquinolone susceptible TB, the strong recommendation is for all adolescents more than 14 years and in adults, 6 months of BPAM regimen has been adopted instead of the initially traditional 15-month longer regimens. So these two have already been adopted by our NTP guidelines, but these two are the new, first and second are the new updates which are going to be soon adopted by us. Other than that, one more big thing, the new recently revised McDonald's criteria. There was a 2017 criteria which was previously being taught everywhere. So that criteria involved treating a patient as for multiple sclerosis if there was dissemination in space plus dissemination in time. So what did that criteria suggest was, if the patient, what were the evidence of MS that patient already have. So if the patient had 2 or more relapses and either objective clinical evidence and 2 or more lesions, then they don't need anything else for diagnosing MS because the patient already has 2 relapses which is suggestive of dissemination in time and 2 or more lesions which is suggestive of dissemination in space, and the patient has objective clinical evidence. So there is no additional data required in that patient. However, in patients with 2 or more relapses which is suggestive of DIT, dissemination in time, with objective clinical evidence, dissemination in space was required, which is by one or more MRI detected lesions typical of MS, or a further relapse showing damage to another part of CNS on follow-up studies. So, however, another category of drug, another category of patient where there was 1 relapse with objective clinical evidence of 2 or more lesions, say brainstem and or cortical lesions, but only 1 relapse. So the patient had shown only dissemination space but no dissemination in time. So we need to prove dissemination in time by oligoclonal bands on CSF, MRI evidence of a new lesion since a previous scan, or a further relapse on follow-up. So another category of patient with clinically isolated syndrome, that is 1 attack or relapse with objective clinical evidence of 1 lesion. So the patient is neither showing dissemination in space nor dissemination in time. In such case, dissemination in space was needed, which included 1 or more MRI detected lesions typical of MS plus a further relapse in another part of CNS, dissemination in time shown by oligoclonal bands, or showing new lesions since a previous scan and a further relapse. However, in another category of patients typical for primary progressive MS, that is insidious neurological progression suggestive of multiple sclerosis, continued progression of 1 year from previous symptoms by ongoing observation needs to be documented to diagnose MS, plus there should be 1 or more MRI detected lesions in the brain typical of MS and 2 or more MRI detected lesions in the cord, plus oligoclonal bands. This was the 2017 guidelines. So you need to just keep in mind this, but however, all these guidelines have now been replaced by the 2024 revised criteria, where the general principles included dissemination is in space is fulfilled whenever there is 2 out of 5 topographics involved showing typical lesions. What are these 5 topographies? There was juxtacortical previously, periventricular, subcortical, but now we have included a new category of optic nerve involvement. As studies showed, optic nerve was the first site to be affected in multiple sclerosis in around 30% of patients. They have now included optic nerve under the new topography. So whenever a patient has or may or may not have a symptom, but any two of these topographies are involved, remember that the criteria for dissemination in space is fulfilled. So dissemination in space and time, we need to diagnose MS as was earlier case. However, if there is dissemination in space plus oligoclonal band or kappa free light chains, there is no need of dissemination in time in such cases as suggested by 2017 McDonald criteria. In patients with typical symptoms, here we know that if the patients had two topographies and no other symptoms, then we can still diagnose MS. However, in patients with typical symptoms, the presence of typical lesions in at least 4 topographies is sufficient to diagnose MS. Okay. Moving on to the next important thing. Patient with typical symptoms, typical lesions in 1 topography and 6 CVS or PRLs plus dissemination in time or CSF positivity. This is sufficient to diagnose MS. So what is CVS? CVS is central vein sign, which I will be talking about later, and PRL is peripheral rim lesions. So we need 6 central vein signs and at least 1 or more peripheral rim lesions, along with dissemination in time and or CSF positivity in the form of oligoclonal band or kappa free light chain. In patients with progressive disease, we need to document 2 spinal cord lesions to demonstrate dissemination in space. So the important descriptors which have been revised in 2024 criteria are the first one, central vein sign. So in central vein sign, you can see that this is the transverse section and a vein is seen traversing through the lesion, which is the white matter T2 flare hyperintense lesion. This lesion, however, when seen longitudinally, the vein will be seen traversing longitudinally parallel to the lesion. So in the MRI study shown here on T2 flare, we can see that the white matter lesion has a central vein traversing through it. So this central vein sign is more prominent when the size of lesion is greater than 15 mm. However, you can see that there is another lesion which is also typical of MS, that it is juxtacortical in location, but there is no central vein sign because central vein sign is less seen in lesions which are less than 5 or 10 mm. So moving on to the next descriptor which has been described in the recent guidelines, paramagnetic rim sign. So paramagnetic rim sign suggests that if there is a lesion like this, which is a demyelinating lesion, which is indicative of multiple sclerosis, active multiple sclerosis will have a ring of iron which shows around the edge. So this ring of iron, as we know, is paramagnetic in nature and hence will bloom on SWI. So SWI sequence is needed to diagnose paramagnetic rim sign. So the importance to note here is that even systemic vasculitis case will present with white matter T2 flare hyperintense lesion. However, on SWI imaging, you don't see any paramagnetic rim lesion surrounding it. However, in multiple sclerosis, the same white matter T2 flare hyperintense lesion are seen to be surrounded by paramagnetic rim lesion of iron deposit on SWI imaging. So the importance of paramagnetic rim lesion in multiple sclerosis has now been included under the guidelines. Moving on to the third important part, we always thought that multiple sclerosis we need oligoclonal bands on CSF, However, now recent trials showed that the kappa-free light chains are more sensitive than oligoclonal bands and hence can be replaced by oligoclonal bands and suggest CSF dissemination in cases with multiple sclerosis. So oligoclonal bands, you can see here, if there is no bands in CSF and serum, this is a negative multiple sclerosis. However, oligoclonal bands seen here in control and in serum, in CSF and in serum patients suggested CSF dissemination earlier. However, you remember that kappa-free light chains basically it means that the kappa chain of light chain is usually has a hidden epitope here because the heavy chain and light chain are bonded by disulfide bonds. The epitope is hidden. However, in multiple sclerosis, what happens is this light chain breaks off. So what happens? The hidden epitope is now exposed, which is being targeted by immunoassay and detects kappa-free light chain. And if it is present, it is more than 77% sensitive for multiple sclerosis as per studies. Other than that, the last topic for today is the new drug updates which have not been included under the first part, that is atrasentan and iptacopan. These are the newer drugs which have been approved for IgA nephropathy. There is one more drug, resmetirom, that is a THR beta agonist, has now been approved for MASH and MASLD. These terms have now replaced NASH and NASLD. So remember that resmetirom is now FDA approved for MASH and MASLD. And we also know that a patient with atrial fibrillation and stable coronary artery disease, we initially used to give edoxaban plus antiplatelet. However, edoxaban monotherapy is found to be superior than edoxaban plus antiplatelet, and hence from now on these guidelines have been included by CDC. We will again make a new video if we feel that there are some topics which we have missed in the recent updates part 1 and 2 under our channel and will be uploaded soon before your exams. Until then, stay tuned for other parts. Stay happy, stay safe. All the best. Do text us if you have any doubts, or do text us if you need any further videos. We are going to have a tumor related videos under the playlist in our channel soon, which is going to be in parts of every tumor. Also, we are going to have subject wise quizzes in our channel which will include interesting questions, so that may be asked in your exams, and how to approach such questions. So subscribe the channel, like the video, and please support us. And for any information for our 20th notebook, which contains all the tricks and tips also needed for NEET, INI or FMGE exam, with strike rates of around 150 plus in recent NEET, you can text us on our WhatsApp, details of which will be provided in description below. Thank you for watching the video. All the best.